All right. Hello, hello. Welcome, everyone. Welcome back to a Rafael Medina subspecialty virtual morning report. My name is Maddie. I'm going to be facilitating the session and really excited for today's session. Today is a primary care focused virtual morning report, and we have two fantastic educators here who are going to be teaching us, and really excited to learn from them. I'm going to eventually pass the mic to both of them to introduce each other because they have worked with each other before. But just to briefly introduce them, we have our special discussant, Dr. Chris Jackson, who is an associate professor at medicine at the University of South Florida. Seems like he just recently transferred institutions, so really excited for you to join us today, and thank you so much for taking a part of the session, Dr. Jackson. And then we have Dr. Tina Dow, who is an internal medicine resident, a PGY2 at the University of Tennessee in Memphis. So I will pass the mic, Dr. Jackson, I can pass it to you first, and would love for you to first, share how you found yourself in a career in primary care. Then we can and then it would be great if you could introduce Tina Dow.
Absolutely happy to do that. I found myself a career in primary care because I just loved a little bit of everything. I enjoy the relationships we build with patients. I love wrestling with uncertainty. Not everything is always wrapped into a nice bow in the primary care office. Like sometimes the answer is we just need time and space to see what happens. And being able to partner and journey with patients on that is very fascinating to me. I think the other thing about primary care that has gotten more interesting is I enjoy chronic disease management, and the idea now that there's this whole slew of different medications and things that I can use to manage chronic disease is exciting. When I joke with my residents when I was at UT that diabetes management changed drastically even from the time I was a resident. I remember when we had uh, G, uh, sulfonylureas, metformin, et cetera. And now we have a whole host of GLP-1, SGLT2 inhibitors that not only help with diabetes management, but chronic kidney disease, heart failure management. And so it's never a dull day as an internist. There's always something new to learn, always a different way we can impact our patients. And so that is what got me excited about primary care. That's what still makes me excited every time I step in the office to see patients. And the other thing that makes me excited about primary care is the ability to be able to teach clinical reasoning and to be able to inspire med students and residents. And that's actually how I know our case presenter. I call her Dr. Dow because she's an MD PhD. And she has had a wonderful career already in Memphis. She's currently a PGY2 internal medicine resident at UTHSC in Memphis. She is aspiring to do pulmonary critical care, and her research interest is in antimicrobial resistance, particularly in the ICU setting. And I have the great fortune to be one of her many mentors. And so it's a privilege to be able to take a case from her today, and hopefully I don't get stumped too bad.
Thank you so much, Dr. Jackson, for sharing your kind of infectious passion for primary care and for introducing Dr. Dow. I am actually currently on my primary care clinic block and agree that there's never a dull moment and lots of really fascinating clinical reasoning in the outpatient setting. So I see why you love it. And we'll pass the mic to you, Dr. Dow, and would love for you also just to kind of share how you developed your interest. I know it's not specifically in primary care. And then after you do that, you can introduce Dr. Jackson.
Hello, everybody. I am currently a second year internal medicine resident at UT in Memphis, Tennessee. And it is my absolute honor to be here tonight. And it's also my honor to introduce one of my mentors and one of the biggest supporter, Dr. Chris Jackson, since I was a medical student. So Dr. Christopher Jackson is an Associate Dean of the Student Affairs and Associate Professor of Medicine at the University of South Florida, Morsani College of Medicine. He's passionate about clinical reasoning, medical education, and mentorship. He completed a bachelor's degree in biology and sociology at Emory University, followed by his MD at the Medical College of Georgia. He did his internal medicine residency and a chief resident year at the University of Tennessee Health Science Center in Memphis, Tennessee, and that's where we met. His clinical and scholarship interests have been in how to promote clinical reasoning and evidence-based practice amongst medical trainees.
Amazing. Well, we have two phenomenal guests clearly, and really thank you both for taking the time to participate in this session. So we will jump right in, and Amal, thank you so much for scribing. You can go ahead and share your screen and pull up the whiteboard. And then Tina, whenever you're ready, you can share the first aliquot.
Okay. So we have a 28-year-old female with past medical history significant for sickle cell trait, hypertension, diabetes with unknown type, and a procedural abortion 2 or 3 weeks ago. She presented to the ED here with a complaint of 2 weeks of diffuse abdominal pain and nausea and non-bilious, non-bloody vomiting that started a few days ago.
Right.
And yeah, no, Dr. Jackson, I know that we're not in a primary care setting right now. She's presenting to the emergency department, but still would love to kind of trickle in some primary care pearls. And I'm just curious from your perspective, how you approach abdominal pain in the outpatient setting, different from the inpatient setting. What do you think are the differences in kind of your mindset, and how are you thinking about this woman?
Yeah, it's a great question. It actually starts out pretty similarly. And so I kind of think of a big four, of things when somebody has abdominal pain in the office. And so the big four for me would be a perforation, a obstruction, a vascular event, and an embolism. So for me, if somebody comes in acute abdominal pain in the office, I definitely can't let them leave the office if I think they have a perforation. Some things will help me with that. Perforations tend to be a bit more acute onset. I wouldn't expect it to last multiple weeks. I don't really have any other data yet about the patient's abdominal exam or their vital signs or things, but in general, perfs I wouldn't expect to be able to go on for 2 weeks. Certainly obstruction comes to my mind. Obstruction can be associated with nausea and vomiting. You know, uh, I would also expect probably some abdominal distension and things. A little bit less likely in her, but certainly vascular events. I think about particularly if the patient was older, had a history of atrial fibrillation or significant heart failure. You can certainly get emboli to the SMA or IMA, and that can certainly cause like bloody diarrhea and things. And then ectopic pregnancy for me is always on the differential, and the classic question on boards and things is young female comes in, abdominal pain, et cetera. What is, the initial test? And almost always they will say that you should make sure you get a pregnancy test, kind of thinking about that. So those are the first four things I always think about. And I always tell my residents, no matter what, even if we have no freaking idea what is going on, they cannot leave the office with us worried about any of those things. At that point, then I go anatomically speaking. And so whether it's right upper quadrant, right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant, and then kind of think more in an organ system based way. And so, typically would think, of course, within the right upper quadrant, we're thinking kind of liver, gallbladder, perspective. If we're thinking left upper quadrant, that's going to be more spleen, colonic. If we are in the, lower quadrants, we tend to think more in the like colitis sort of picture. Of course, we have to worry about the appendix if on the right side. And then, of course, we also have to think of kind of ovarian pathologies as well. So could this be torsion? in the case of an ascending STI, things like Fitzhugh-Curtis syndrome. Now, one thing that adds kind of a particular interest here is the sickle cell trait. And so there are certainly things that come to my mind there. You can get like hyperhemolytic crises that can impact, the liver. Certainly might be a little bit more of a proclivity towards an embolic event or just the sickle cells in and of themselves impeding blood flow. Um, Otherwise, and then to some degree with sickle cell disease, I would also worry about, again, risk for kind of underlying cardiomyopathy as well. Those sickle cells can predispose to a little bit of right heart failure and with that pulmonary hypertension, et cetera. So those are some of the initial thoughts that come to mind.
That was a brilliant initial dissection, and I loved kind of just you laying out kind of the similarities and ruling out kind of the do not miss highly morbid causes, whether outpatient or inpatient. And it was very cool to see how you incorporated the sickle cell trait. I'm curious, the other thing that jumped out to me is that this is quite a young person, 28 years old, and I'm curious if you're thinking about this any differently given the young age and that this is probably, at least the patients that I've seen in the hospital are significantly older than this. How does the fact that this is kind of a young woman affect your reasoning?
I think it's a great question. I think certainly for me, if I'm going at the first part of the schema, kind of thinking of perf obstruction, vascular, embolic things, certainly, obstruction with the history of the recent, procedural abortion, maybe the vascular thing with the history of sickle cell goes up. I think things that would go down on my differential would be any sort of malignancy associated things, just because those tend to be a little bit more common as you get older. Um, I want to be careful. I think there can be a bias to presume that there could be more infectious causes, early on, and not as much an infectious cause for those that are older. But I, try to really make sure I don't necessarily zero in on that. And so, yes, I guess, could be more infectious, but I also just try to, again, keep myself a little bit anchored that, age necessarily does not rule in or rule out infection. Um, I will say, again, embolic events may be also just a little bit more common, I would expect, in older patients typically, unless, again, we're thinking of like some sort of hereditary, embolic syndrome. And then those would be a little bit more common in those that are younger.
Amazing initial thoughts. Thank you so much. All right, Dr. Dow, back to you.
Yeah, so a little bit more history about her. So the last episode of vomiting was in the morning before we met her that night in the ED. She stated that her abdominal pain started around the umbilical area and described it as a sharp, but now moving to a suprapubic and bilateral upper thigh area. She denied any fever, chills, diarrhea, cough, vaginal bleeding, or changes in vaginal discharge. She is sexually active with one partner. She reported no history of STIs. She's not taking any medication daily. Um, and one interesting thing is that the patient does not want to urinate, although the bladder scan showed about 600 cc of urine.
Mm, okay. Okay. This is very interesting. And so, for me, of course, when you start bringing in suprapubic, I'm thinking something urinary tract related. So my mind goes to like, everything from cystitis, urethritis, pyelonephritis, urolithiasis, nephrolithiasis. I do want to put a pin in that, she said that she doesn't want to urinate. And so I would want a little bit more data about that. Does she not want to urinate because she physically can? Does she not want to urinate because it is quite painful, like I would expect maybe with the urethritis? The fact that it is kind of umbilical to me suggests that it's something traveling up from the bladder. And so, again, one thing I think of is just like an ascending infection. So again, that could be pyelo, that could be also Fitzhugh-Curtis, or what would be like what is it, perihepatitis in the setting of like PID. Those things are really climbing up on my differential. The other thing I guess I'm wondering about is how is, in general, most people would be triggered to go to the bathroom when there's more than 300 cc's in our bladder. And so if it's 600, again, just makes me also wonder about, while a little bit more rare, and I would have to get more a history from her, I've also seen endometriosis affect the urethra, and cause basically like a little bit of a essentially outlet obstruction. And so if she had a relevant history of dyspareunia, dysmenorrhea, that would also be a consideration I have in my mind. But I'm very curious about the, inability to urinate. Um, I will say that the absence of fever here doesn't necessarily rule out infection for me at all. If it were present, helpful, but its absence doesn't necessarily rule anything out for me. And then, again, the vomiting at least suggests something. It would suggest that whatever process going on is, again, not just isolated to, in this case, the bladder things, but again, it's probably ascending up.
Yeah, that I loved that potential connection of like endometriosis with abdominal pain, but causing an outlet obstruction. That was a really interesting way to tie things together. And yeah, I think it was a really interesting detail that Dr. Dow shared about, not wanting to urinate or inability to urinate with the 600 cc's on a bladder scan. And right now we don't entirely know if it's an inability to or a lack of desire to, but if we were to assume that she was unable to urinate, would you be translating that into urinary retention, and how would that affect your reasoning?
Yeah, so if she's really unable to urinate, the things I start to worry about is something has compromised the neuro supply to the bladder. Now, we don't have a report of back pain or anything yet, but certainly if there was like back pain, leg weakness, then I'm starting to think what's going on in the lower part of the spinal cord. Um, I'm not aware of a connection between sickle cell disease or sickle cell trait and causing some sort of, autonomic neuropathy or dysregulation of the plexus, that supplies the abdominal tree. That would be something I could think to keep in mind. Um, we don't have any history of diabetes or something else that would make me worried. So that is kind of where I'm leaning right now, is that again, what's the nervous supply going to the bladder? Is it somehow compromised if she's not able to urinate, despite having 600 cc's in her bladder?
All right, thank you. Dr. Dow, back to you.
Yes, so during the history taking part, it was very difficult to get answers from the patient. So most of the questions were answered by her mom at the bedside. And later that morning, patient began to be nonverbal, responding only by grunting and nodding or shaking her head. A few days later, she began to be less responsive, necessitating repeated stimuli for interaction. And then her mentation became waxing and waning. And so we were doing a differential and doing some workup for her acute encephalopathy.
Okay, I did not expect that turn in the case. And so, uh, in general, when somebody comes and they're having like an acute, mental status change at the bedside, I think of simple things first, don't miss these things, dextrose, oxygen, Narcan, thiamine. So, is our glucose somehow low? Treat that first. If oxygen low, maybe that's an indication CO2 is high. Narcan, if she was receiving, opioids or something for pain. And then if we had any like alcohol use history or something, she would certainly be at risk for kind of a Wernicke's, encephalopathy, and that's where thiamine can come into play. And then I would kind of go into the missed mnemonic from CP solvers, metabolic infection, structural toxins. So, for me, infection and toxins tend to hit you pretty hyper acutely. Metabolic and structural things tend to be a little bit more subacute. I'd be worried more about something metabolic going on here. She's been, vomiting a lot, decreased PO intake. Maybe she's developing sepsis, lactatus through the roof or something. That would be one consideration, but I'm definitely worried that she's now pretty much gone to being acutely encephalopathic. So in my mind, if we haven't already begun to think about imaging her belly, she definitely needs some belly imaging stat to make sure not an abscess, sending infection, things getting worse. Um, Trying to think of anything else in my mind coming into play. I suppose with kind of sickle cell trait and things like that, there is kind of increased risk for embolic things. So, stroke is possible. I think maybe a little less likely in my experience. Stroke doesn't necessarily make you wax and wane. That usually is a more acute confusional state that's persistent. Although I suppose if it were something to the posterior circulation, maybe you would be a bit more sleepy and things. Uh, Certainly, again, are we giving her things or was something taken exogenously that could be causing the change in mental status is something else I would be keeping in mind. And then if we haven't already got blood cultures, again, worried that this generalized to, bacteremia, that would be another consideration that I'd have for this particular patient. Um, but just trying to lay on altered mental status as well as this abdominal pain, I'm really worried about, abscess formation, ascending infections such as Fitzhugh-Curtis. Um, I still don't think it's a perf, but certainly could be trending that way. Those are things that come to mind.
Yeah, Dr. Jackson, I thought it was really phenomenal. Kind of, I feel like I could see the different Venn diagrams you were laying, the altered mental status and abdominal pain, altered mental status, how does that overlap with sickle cell traits? So it was really phenomenal to hear your reasoning through that. And I also really appreciated the kind of very practical thoughts that you have in the moment. Is this a situation for dextrose, Narcan, oxygen? Those are fantastic practical tips. And then, Dr. Dell, if I could just ask you a quick clarifying question, just so that we're on the same page with kind of the time course, the kind of acute change in mental status where the patient became unresponsive, was that as you were admitting her, kind of before she had spent several days, or was this several days into the hospitalization? I think to the point that Dr. Jackson made of like, is this related to pain medications or something? How far into the hospitalization or to the patient's care did this happen?
Yeah, so initially when I met her in the ED, she was alert, oriented, but was not talkative. So mostly she answered question by shaking her head or nodding. And like I mentioned before, her mom provided most of the medical history. And then about 2 to 3 days later, when she was admitted, she became more and more somnolent, but still arousable to voice, and then became nonverbal.
Got it. Thank you for clarifying. So it sounds like when she was admitted, she was already
Hmm.
not extremely verbal, and then it kind of
Yes,
progressed.
getting worse.
I see. Dr. Jackson, I'm just curious if that like time course influences any of your thinking or not so much.
It does. I mean, for me, maybe it takes toxins a little bit lower down. Again, I tend to think of those as being pretty acute. Um, Again, probably I'm thinking a little bit more metabolic structural across kind of that missed, framework. Um, yeah,
And her
that'll motivate.
UDS and UA were negative.
Okay, perfect.
Yeah, Dr. Dow, do you want to kind of share what if you were taking care of the patient, what you were thinking in this moment and kind of what happened next?
Yeah, so initially when I first admitted her, we were thinking about CID with a history of procedural abortion and some kind of abdominal infection. And so we did some abdominal imaging, but it came back with thickening and enhancement of the colonic bowel loops in the transverse and descending colon, suggesting colitis, but no small bowel obstruction.
Hmm. Very interesting.
And Tina, do you want to give like a little bit more information and then we can pause for Dr. Jackson's discussion? Or if you prefer to pause here, that's totally fine, whatever your preference is.
Yes, I can give vitals and the labs. So vitals were, she was afebrile, she was tachycardic with a heart rate in the 110s. She was hypertensive with blood pressure of 150s over 100, and setting well in the high 90s on room air. Labs were notable for leukocytosis with WBC 12.3, low potassium at 2.4, elevated total bilirubin at 1.3, elevated AST and LLT 53 and 121 respectively. Glucose 276, creatinine was normal 0.6, and an elevated GABA of 18, and elevated lactic acid at 2.5. Negative pregnancy test.
So this is, yeah, clearly a very kind of scary situation with a young woman's change in mental status and just curious, Dr. Jackson, kind of what your thoughts are, kind of putting this all together and where you think you would be going from here.
So I'll ask a clarifying question, then that'll kind of help me. I'm curious, when these vital signs were taken, what was her abdominal exam like?
Yes, so her abdominal exam was mild tenderness, diffuse C in 4 quadrants, but
Mild
no
diffuse.
peritoneal signs or anything.
Okay, so mild diffuse tenderness, but she allowed you to examine her would, make me feel better that, again, not peritonitic. So I think at least perforation is a little bit less likely. You didn't comment that the abdomen felt really firm or anything. So I, again, think maybe obstruction is a little bit less likely with that, as well as the CT finding. Um, I am curious about, that is significantly low potassium. And so that, I guess could make sense with all the vomiting that has been going on. Um, the ALT being so much higher than the AST does suggest some sort of focal process going on with the, liver. Again, I would be curious if there was like an ultrasound of the liver to look for like perihepatic inflammation. Is there, new ascites development around the liver? Or is the liver just really big? Is there hepatomegaly in the setting of like a clot in the portal tree? Those are some things that come to my mind initially. I want to clarify, was the glucose 176 or 276?
276.
It's 276. So glucose being that high, you didn't say the patient had a history of diabetes, but certainly that's pretty high, sugar in the setting of an acute infection, somebody that didn't have this history before. And so, um, you know, could we be dealing with Hickham's dictum and, this patient not only has infection, but also has, gastroparesis or something like that going on as well? That would be in my mind. Um, the other thing that just comes to my mind, again, I'm not used to seeing glucose is that high either in someone that's had doesn't have a history of diabetes, but just throwing out something, if there's like a glucagonoma, that would be something that even in the setting of acute infection could give you that. Um, the other question I have is what does her urine look like?
Her urinalysis was negative for UTI or any STIs.
And uh, anybody lay eyes on the color of the urine?
We did not, unfortunately.
Okay, no problem. Again, just broadening out the differential and things like that. You know, an unremarkable CT of the abdomen, you start to think of like also image negative abdominal pain causes, and there can be things like, DKA, hypercalcemia, etc. I've seen a few cases in residency of porphyria as well. But usually you would expect the urine to almost kind of have a chocolate color to it, or at least a darkened color, because as it comes into contact with the light, you would see that. Um, those are just a couple of thoughts, but I'm very fascinated. I'm trying to overlay AMS, elevated liver enzymes, abdominal pain. I'm again still thinking somewhere in the infectious route, or still thinking that there's something blocking flow in the portal tree and backing up into the liver. Um, those are the thoughts that come to my mind right now.
Yeah, I think that's phenomenal reasoning. And I agree that in this case, it's very challenging to kind of figure out what is the dominant problem we're solving now, and to what extent these lab abnormalities are signal and help in the final diagnosis, or just kind of consequences of whatever disease process this is. Dr. Dow, I'm curious if you could kind of share what your thinking was at this point, what was on your differential, and then ultimately you can kind of share additional data, what you guys did next.
Yes, so at this point, we went ahead and ordered an ultrasound of the abdomen and also of the transvaginal ultrasound. So the abdominal ultrasound showed normal liver, no focal abnormalities. The common bile duct was 1.8 millimeter, which is normal, no dilated intrahepatic or extrahepatic biliary ducts. Gallbladder debris and borderline wall thickening. Murphy signs negative. Kidney is normal, and the pancreas is unremarkable. And on the Doppler, the flow toward the portal vein is directed to the liver. Aorta and IVC are unremarkable. And the ultrasound of the pelvis showed normal appearance of the uterus and endometrium without finding to suggest retained products of conception, normal bilateral ovaries. And so at this time, we focus on her encephalopathy and order brain imaging. So CT head came back with no acute intracranial findings.
And Dr. Dow, would you like to pause here? Okay. So yeah, Dr. Jackson, we have a lot of imaging, and it seems like we don't have an answer yet for this acute encephalopathy in this young woman, and definitely a very tricky place to be in. But I'm curious kind of what you're making of all the negative imaging, and what you feel like is left when thinking about this acute encephalopathy with negative workup so far.
Yeah, so um, there's some things that are reassuring. Certainly the CT head being negative, I think for sure can tell you that there's not like a hemorrhage, subdural, um, less subarachnoid. I would expect that to be more acute, but I don't think that there, is significant hemorrhage. If it were an older person, of course, I'd be worried about like a normal pressure hydrocephalus or things as another differential in mind. I would say that if the concern was for stroke, this is still in a window where MRI would probably be better to actually rule that out. Although again, my thought of stroke is actually a bit on the lower side. I am impressed and intrigued of the abdominal imaging all being negative. I, kind of learned in my residency, when imaging like that surprised you, it's never a bad thing to go down and talk with the radiologist and basically say, "Are you sure?" Because, I have suggestions that labs and other things, might be, showing signs that the liver is involved in things, even though the imaging, is suggesting otherwise. And so I kind of just have in the back of my head maybe a conversation with radiology, and then a question of, is any other imaging going to be helpful? It is helpful to me to know that the common bile duct, is not significantly enlarged. I can't really say that there's a clot now or anything like that going on. Um, so that is helpful, I guess, to kind of rule that out as a cause. And then, of course, also the negative ultrasound of the kind of transvaginal area, makes things like torsion, things like that a little less likely. For me personally, this patient is lending themselves to potentially needing an LP, because I cannot explain the altered mental status, at least with the data given so far. And so I would, wonder if the team would, do an LP. Um, you know, Common kind of things that I see in this particular age group is like an NMDA receptor encephalitis, is kind of one thing that comes to my mind. Um, Also seen like weird presentations of NMO, although I would expect more visual findings or other things with that. Um, the other possibility, not that you necessarily need the imaging or to the LP to find this out, but elevated blood pressure, not really responding, no other things, always keep press in the differential as well. Um, those are things that, come to my mind, but I'm stumped. I would probably LP this patient. I'd, you know, potentially, consider, whether or not, still treating potential infection till proven otherwise. Those are the things that I would do, and call on colleagues smarter than myself.
Uh, I just wanted to say this is like an absolutely brilliant discussion. I think this is a very tricky case that Dr. Dow is giving us, and very scary. Abdominal pain, acute encephalopathy in this young woman that came on suddenly with imaging, not giving us an answer. And then so I think your differential and the direction of an LP is um, seems just spot on. And I would be asking for a lot of help in this situation. So just brilliant reasoning, and thank you for being so authentic in that. Dr. Dow, I will turn it back to you to please teach us kind of what happened next.
Yes, so at this point, we also considering seizure as one of the differential. And EEG was ordered and only demonstrated mild diffuse slowing, no specific findings. We also consider catatonia and consulted psychiatry, but psychiatry didn't think it's a psychiatric cause. So LP was on the table, but before we go into the LP, we also order an MRI. And before the MRI was done, we also get more history from a boyfriend who later came to the hospital to visit. And we found out that she was having nausea and vomiting for 2 or 3 months before this admission. And so we finally got the MRI back, and it showed Wernicke encephalopathy. So high dose of thiamine was ordered, and we also took her to the LP by IR, but she ended up coded on the table and later suffered a PE arrest.
So just a really kind of tragic and surprising turn of events. And Dr. Dow, would you mind just clarifying? So the MRI, I'm just also for my learning and for probably a lot of people here, when you say it showed Wernicke's encephalopathy, what exactly did the MRI show? If I'm not sure if you have that information available. I'm just curious how they came to that conclusion.
Yes, so the MRI brain showed significant hyperintensity on T2 flare in the pulvinar nuclei and also the periaqueductal gray matter in the mammillary bodies. suggesting Wernicke encephalopathy.
So, Dr. Jackson, maybe I'll pass it to you. And, there's been a lot of really surprising parts in this case and very, very challenging to kind of reason through, especially, when someone's acutely encephalopathic, the history is limited. I'm just curious what you make of this additional workup and what your thoughts are.
No, I think certainly I feel so sad for the patient and their family that, this was the end to the case. Um, Obviously, hindsight is 2020, but I would be curious from the patient's significant other, was there a significant alcohol use history? Because um, it's for me, I tend to think of Wernicke's, heavy alcohol use. They're in the hospital for a couple of days, not drinking alcohol, and then all of a sudden, we kind of find it out of the deficiency. So that would just be just a curiosity from my end. I think the workup, applaud the team, makes sense. We get a lot of EEGs. One thing that I think is underappreciated is that while EEG, we sometimes always kind of think of convulsive status. I have been humbled in residency multiple times by non-convulsive status epilepticus, where they're not really responding, not really doing anything. And unless you got a long EEG, you really wouldn't be able to tell that. And I have lost some patients in residency to non-convulsive status because we just didn't pick it up. Now, granted, they were usually older. So I think the EEG is important. The MRI certainly, I think, is very valid. I don't know that I would have been looking for Wernicke's on it. Probably for me, I'd be looking for, something sitting in the posterior circulation that could explain depressed mental status, nausea, vomiting, because you just don't have that much space back there. So the Wernicke's is a bit of a surprise to me in that way. I think what I'm struggling with is that I still don't necessarily know, without more of the social history or something, I don't know that I can tie it to all the abdominal pain, nausea, vomiting from the beginning, unless it was just simply the patient was drinking a lot of alcohol, got sick on the stomach, started having vomiting, wasn't eating, uh, and then that kind of brought them to the hospital. So that part is still a little bit fuzzy to me, but.
Yes, so we talked more with the boyfriend, and he said that she doesn't drink alcohol. But before the procedural abortion, when she was pregnant, there was a lot of nausea, vomiting. So we think this is from hyperemesis gravidarum, and
Wow.
eventually causing nutritional deficiency that causing Wernicke encephalopathy.
Got it. Okay. 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 No, that pulls it together for me. I mean, we've certainly taken care of people with significant hyperemesis gravidarum before, and so I could certainly see, that being the case. Wow. Fascinating.
And
Fascinating.
before we hear from Dr. Dow more about, because I would love to hear from you, Dr. Dow, about what it was like taking care of this patient and kind of what you learned about Wernicke's, but Dr. Jackson, maybe I'll just pass the mic to you, and even just curious to hear kind of your learning, your teaching on Wernicke's encephalopathy, kind of if you've seen patients as in residency or as an attending, and even if it, was not in this context, if it was more from alcohol, would just
Mhm.
love any teaching that you could offer on this condition and what you feel like is more of a typical presentation of it.
Yeah, the biggest things that I remember from Wernicke's encephalopathy is that it's usually a diagnosis made on the floor and not in the ED. And so for me, it's always why I have that don't mnemonic in my head, because, they're usually fine when they hit the ED door, and then it's the days in the hospital. It's kind of similar, I would say, to like alcohol withdrawal. You usually don't make that diagnosis in the ED, at least the DT's part. Like usually you bring them in and then unfortunately they progress to that point. But Wernicke's, certainly can see the altered mental, status. You can see the MRI changes that Dr. Dow mentioned. Um, I am vaguely in my brain remembering some extraocular movement impacts of Wernicke's, and they are just escaping me at the moment. But I do know that you can find, I want to say maybe some ophthalmoplegia or things with Wernicke's is kind of a finding, but I let my neurology colleagues do that because they do those exams much better than I do. Um, and the other thing is the remarkable turnaround usually that they get when you give them thiamine. I mean, like usually within a day, they can improve with thiamine. And so that is some things that come to my mind. The other thing to remember, of course, is, with like kind of a chronic thiamine deficiency, you can get, what is it, like a beriberi, like a cardiomyopathy type picture. I want to say it's like wet beriberi versus dry beriberi. So that's usually going to be more kind of a chronic type picture. But I do think this case highlights that, you can get nutritional deficiency if there's a lack of PO intake for a long enough period of time, as in the case of this particular patient, it sounds like. But those are some of the teaching and things I know. And I'm sure if my good friend Robbie Giha was on the call, he probably has a very wonderful long thing on it that I don't that I don't recall. I'll probably have to ask him for it, but those are some of the findings that I can remember.
Yeah, that was fantastic teaching. Thank you so much. And yeah, I think also Dr. Dow, maybe I can turn it to you, and I would just love for you to share, yeah, how kind of you were putting this case together and what you learned about Wernicke's encephalopathy.
Yes, so it was very difficult to follow up with the patient case when I was on night during this time because we keep running into no acute findings, normal findings on all of the images until the MRI. But I guess what I learned from this case was that when in doubt, give thiamine during acute encephalopathy. Um, so this is my takeaway from this case.
Yeah, and I guess a few questions I had. So it sounds like, unfortunately, the patient passed away before there was any like improvement that was able to be seen after giving thiamine. Is that right?
Yeah, I think we gave her about 2 doses of thiamine before she was going to IR for the LP, but unfortunately she was coded on the table.
Jeez, that's really horrible. I'm so sorry about that outcome. I think what's also just striking to me is, I guess, all of this we're presuming is from thiamine deficiency, and we're presuming is from kind of the poor PO intake and vomiting for the past 2 months, it sounds like. And I think something that I want to look up afterwards, and I'm curious if anyone knows the answer, is just like how long it takes to become such severely thiamine deficient to the point where you have um these consequences. Like, is it 2 months? Do you have like, yeah, that's just my reflection here of yeah, how long does it take to become this thiamine deficient? Like, was it just over this 2 month period, or is this more reflective of that she had been deficient in thiamine for a longer period? I don't know the answer to that question, but that was just something that stood out to me about this case. Um, maybe Dr. Jackson, before we end, I could just pass the mic to you for any last reflections, and if you wanted to just highlight, one or two teaching points to emphasize for those listening.
Absolutely. I was actually looking up your particular question around, how long does have to be, and I found this wonderful, concise review from Mayo Clinic Proceedings by Sinha et al. And one of the first things they mention is that Wernicke's encephalopathy can occur in any patient with a nutritional deficiency state, such as hyperemesis, intestinal obstruction, and malignancy. And so I think for me, this kind of helps broaden my frame of Wernicke's, not just to be centric on the use of alcohol, but really to think more of like what's causing, nutritional deficiencies. The other thing that also comes to mind for me is just the importance of not forgetting the practical things. In my teaching with residents down at UT, I always used to say, if you find somebody acutely down, don't miss these things, you know, and this was an example where that actually can be pretty helpful. I think the other, important, kind of consideration here is the importance of taking diagnostic timeouts. Um, Even for me, it was hard. I wanted to make this fit infection so bad. And there are so many things that were giving diagnostic momentum to infection, but then it just wasn't squaring well with the imaging findings and everything else. And so, you know, if it doesn't fit, you need to consider something else. And so I think being able to keep a broad differential it becomes very important in cases like this. But no, it's a fascinating case, and I got a lot of reading on Wernicke's to do.
Yeah, Dr. Jackson, I just wanted to say I thought your discussion was absolutely brilliant. You were so authentic in your reasoning, and I really appreciated how uh you could just were very focused on what you would do in real life. And, with this acute encephalopathy, what are the things that we need to act on immediately? So really enjoyed your discussion, and thank you for being so authentic in it. And Dr. Dow, I will pass the mic to you to share any other reflections, and also if you wanted to highlight one or two teaching points that you learned from this case.
Yes, so I know that today is more for primary care cases, but I think that one thing that I can bridge this takeaway from this case to primary care is that we need to consider about supplemental nutritional um, supplements when a pregnant patient comes into the clinic, because cases like this is kind of difficult to navigate when the patient ended up in the hospital afterward. And thank you for having me on CPS Solvers tonight.
Yeah, thank you both so much for taking the time. And yeah, to emphasize what Dr. Jackson said is, I definitely have an association of Wernicke's encephalopathy with alcohol use, which I'm sure is a large percentage of the cases, but it was definitely a humbling reminder that just any causes of thiamine deficiency, whether it's from poor PO intake and vomiting, as in this case. So thank you both so much for taking the time and for your fantastic discussion. And I hope to have you both back on VMR in the near future. And
Awesome.
big shout out
Having
to Teresa for jotting down the great teaching points, and to Amal for scribing. And Dr. Jackson, were you saying something?
well, now just saying thanks for having me.
Of course. Well, we'll end the session there and see you all next time.